Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need.
How often do you find it necessary to extract the bottom incisors? It seems like whenever we radiograph them, no matter the age, there's 50% bone loss. Yeah, incisors are typically one of the first teeth to go, even in those younger patients. And, you know, they're single-rooted, they're small teeth. And if there's been any inflammation and early periodontal changes, we're typically going to see it there, as well as the caudal mandible. And so we're on the lookout. And the earlier we catch that, the better. Sometimes we can get away with root planing and hopefully saving those incisors, but sometimes they just got to go. So it's really, really important that we evaluate on a case-by-case basis, but it's not unusual. Statistically, I don't know the percentage of patients, but we do a fair amount of incisor extractions. That's one of the, the earlier changes that we see. Have you and your veterinarian seen good success managing CUPS cases if the owner is ultra diligent with home care? And Nancy, this is a great question, and unfortunately the answer is no. Depending on how advanced those lesions are, and the ulceration sometimes can be full thickness in some of these areas, and we've had those owners that really want to try and do home care, and they'll do everything that we recommend: brushing twice a day, rinses, chews, anything that we can do to minimize inflammation, minimize plaque, because that's the big component with those canine chronic ulcerative stomatitis cases. And in the last 11 years, I think we've had 2 patients that were successful, and that's only because the lesions were very, very mild. They were just starting to become inflamed. They weren't that kind of true ulcer. It was more or less inflammation on that mucosa. But everyone else, extractions was the treatment plan. And the good news, especially in our canine patients, I've never not seen that fail. And sometimes it's individual teeth, sometimes it's full mouth extractions, depending on the case, but they resolve. And the patients are so much happier, much better quality of life for the remainder of their life, absolutely. What do you normally charge for a 2-week post-op? Ours are complimentary, but follow-up care has a recheck fee. So we're never in an office 2 weeks later. We don't typically see them 2 weeks post, and very rarely do we do recheck appointments just because we know these patients are going to heal. We do recheck large advanced surgeries like full mouth extractions on a stomatitis cat, en bloc resection of oral masses. And we do those at the 1 month mark because we're in these offices once a month. Those visits are included in what they've already paid. The 4 and 6 month visits are separate. Those are additional fees to include anesthesia, x-rays as needed, and a cleaning and any periodontal therapy or extractions if needed. So those procedures we're charging for, but any recheck exams are already included. On average, how many teeth may need root planing on a pet? Is it common to see just one tooth, or will you see a few? Jill, good question, and this varies case to case. Sometimes we only do one area. Sometimes we have to do several quadrants. Just really depends on the level of disease in that particular patient. So I don't really have an average number. It is strictly case by case, and it varies. When scaling in dorsal recumbency, do you place gauze in the back of the mouth or trust the tube cuff inflation? Yeah, and again, this is a pretty common question, and so I'm glad we can talk about this as well. Good question, Cindy. We sometimes will place gauze in the back of the mouth, sometimes not. That gauze gets saturated very, very quickly, and unless you're changing it, every 15, 20 seconds, it has some benefit with, big chunks of tartar getting down there a little bit, but water, debris, blood is still going to get through there. And so as our standard protocol, we will, before recovering this patient, clean out that throat. So this video kind of illustrates that as well.
One thing that we always do in our patients after any dentistry procedure is make sure that the airway is clear around that endotracheal tube and in the caudal oral pharynx. So what we're doing now is positioning this patient in order to visualize that. Ideally, you have the person that is holding the maxilla, person that is holding the endotracheal tube and the tongue and using the cotton-tip applicators, and then you have someone else that is giving that person the cotton-tip applicators, either one or two, depending on where you're at in the oral cavity. So this is absolutely critical. Clear around the trachea, clear in the trachea if there's any debris there as well, and you can ensure that there's a free airway upon recovery.
So that's something we do with every single patient, even if they've had just a cleaning, which is unusual. But even if they haven't had oral surgery, we're going to place them in sternal recumbency. So we're going to clean out that throat because there may be mucus, maybe water, and make sure that that airway is free. So that's just standard protocol for every patient so that we can make sure that we've got a good clean airway and that we're not having any aspiration or respiratory issues, airway issues on recovery. What type of suture do you doctors use for dental procedures, cutting or taper? We will use cutting. Oral tissue, the taper needle, very hard, excuse me, hard in some cases to get through that. So a cutting needle absolutely is needed. And the type of needle, FS2 or NP3. And then as far as suture goes, in those dogs above 10 pounds, we're going to use a 4-aught monocryl. There's a number of different types of suture out there. Chromic gut is a popular one, but that dissolves too quickly, and it has a lot of drag going through that friable, delicate oral tissue. Monocryl goes through very, very nicely. So 4-aught monocryl, 10 pounds and over, 10 pounds and under, dogs and cats, we're using 5-aught monocryl. That's really the only suture that we use, those two sizes, and then the FS2 or NP3 needle for closure. All right, lots of questions here about what techs can do versus veterinarians. And yeah, I'm glad to see this because it is kind of a gray area, with regards to extractions and oral surgery and all of that. So we've got, Deborah asked about AHA accredited. Are technicians allowed to administer blocks? Absolutely. This is no more than giving an injection. And so this is not considered a surgical procedure. And technicians, veterinarians are there to do surgery and diagnose. Our job is to do pretty much everything else. And so nerve blocks absolutely fall within that wheelhouse. Technicians, I was at a practice where we were doing a lot of orthopedic surgery. We were doing epidurals. And so when you have the correct training and are confident in what you're doing, absolutely technicians should be doing that particular procedure because it helps move that case forward, whether the veterinarian is available or not. So we're not waiting for the veterinarian to have to do that to move that case forward. Do you suture dental extractions, or is that always left to the DVM? In rare cases, I have closed. The flap is already prepared. The surgery has already been done as far as the extraction, bone debridement, tissue debridement, and all I'm doing is putting sutures in. And this occurs if we've got to get him onto another patient, or if he's got to see a patient and we're trying to shorten that anesthesia time as much as possible. And it's in very rare cases, but I have closed. So that's a good skill to have, because if it's needed in a pinch, we can certainly still move that case forward. Is it on a regular basis? No. Typically, Dr. Beckman is closing all of the flaps. But again, the majority of the work is done. All I'm doing is just sewing it back up. Does the technician typically do the root planing, or does the veterinarian? Again, good question. Closed root planing is not a surgical procedure. We're just using a curette going into that pocket, and that's on those pockets that are less than 6 millimeters. And we're doing that subgingival curettage as well on that pocket like you saw in the video. If we need to do what's called open root planing with a bone graft, that is done by a veterinarian. Because a flap needs to be created for those deeper defects with bone loss, we need to open up a flap to get better visualization, to clean that area out, and then place that bone graft, and then it's suture closed. So that is definitely a surgical procedure done by a veterinarian. So closed root planing, technician, and I do almost all of the closed root planing. And then the open root planing with bone graft is a veterinarian task. What anesthesia tubing do you use for a feline patient? We break it down by weight. If they're 10 pounds or less, they're going to go on a non-rebreather. So regardless of species, so typically our kitty cats are on the non-rebreather.
I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.